which I have conducted a lot of webinars online. I hope you like my lecture, and I'm really eager and passionate to share my InnerScience journey with all of you. So today we are going to talk about the different treatments on teeth. And by the next few hours, you have a lot to take home and to treat your patients with teeth. So you can add me on Instagram. As you know, teenagers, a lot of them have Instagram. So you can add and like me. And to start the lesson today, we are going to, I'll walk everyone through a clinic overview of my clinic in Taipei. I have a 7-chair unit in the clinic, everything digitally set up, and a lot of equipment as a lot of your clinics have. So let's watch a video of how every day is in my clinic. It's a white platform. And we have 2 scanners as well, so that we are able to incorporate all our patients with scanning for any treatment, including orthodontics, implant, and prosthodontics. And we do our consultation just by the chair. Even though we have a consultation room, but it's very handy and it's very convenient for us to use the screen and show the patient. And we also, all our staff knows how to scan, but I have delegated some of my staff for a faster scanning. It's very easy for them to put patients on the scanning and to take records, which is a very critical part of our everyday record taking for our case submission. Easy for them to utilize as well in their daily routine. And all of my patients, except for first, we will always take the CD and upload the CDs for submission. So we're able to see the roots during ClinCheck planning. And we do submission on the day that we take the scan and the records. A lot of testimonials. We have the graduation therapy for every of our team patient after treatment, and they love it. They have a lot to tell us and our team as well. So this is a small walkthrough of the clinic of what I see in Taiwan. So together we are going to make a difference for our patients. So as for today, we've been amazed by the new advances of the new iTero Lumina that's coming, and for the future, there's a lot coming. And after 2009, after I was accredited and certified with Invisalign, I started my Invisalign journey. And it's not until this recent few years that I adopted the digital workflow. So Invisalign is not only clear alignment, it's a system for our patient, for our clinic. And I adopted the clinical workflow, but I have customized according to some of our needs in the clinic. I do the scan, plan, and alignment delivery as to suit my time and our workflow in the clinic. And I'm going to share some of them today in the lecture. So, by going digital, we are going to have a lot of advantages. It doesn't mean that we are going to take less care of our patients, but by going digital, we are going to have more time for more patient productivity, and we are going to be more efficient. And we are able to provide more precise treatment for our patient that is repeatable and that is more highly on the patient experience. Because anything that is precise and accurate, it's gonna save a lot of time, not only for our patients, but also for our clinic. So today, it's a long topic for team to just finish in a few hours. So I'm going to break down the talk into some overview of team treatment, because a lot of doctors there are scared of how to do treatment on teams because they think that teams are hard to boost the compliance and teams are hard to to be with. However, if you're able to tackle teams and more able to cooperate with them and to communicate with them, it's gonna help with the compliance in their alignment layer. And then we are going to delve into the world of the different treatment of class 1, class 2, and class 3 malpollutions. And we are going to end the day with some practice management and patient journey of my team source. And we are going to end up the day with a summary. So, what is particularly important when we are doing team treatments? As I've shared earlier in the day, that there are 6 pillars of team treatment that boost the success of a team practice. However, to me, there are 3 keystones that are very important. The first is the clinical efficiency and the efficacy of the product you're using. By this, it means that if you have something that is very effective and that is very precise, it's gonna boost the treatment and it's gonna boost the result in our patient. And it's gonna get us more referrals. And in this one is the product of choice because it's very comfy and it's very aesthetic and teens love it. And the pain is really minimal, that they are more acceptable to it. And there's a lot of marketing going on and they think that they're using something that's very trendy. Even my kids at home, they also ask mommy, can I have some sort of Invisalign because my classmates are using Invisalign. So they know that Invisalign is the trend for treatment of fixing their teeth nowadays. And second of all is the patient. No matter how well trained you are with your skills, if you neglect how the patient feels nowadays, you're not going to get any referrals. So patient experience is a big part in our treatment now. And of course, how the appliance and how the digital system is going to help with your workflow. It's going to increase the productivity. It's going to decrease the complexity of the workflow and to decrease the complexity of staff training in our team. So some principles of team treatments that is different from other adult treatment is in that with teams, we're not only treating the teeth, but we're able to change the direction of the bone to a more favorable position so that like for class 2, we are able to change a mandible retronephrism into a more full harmonized facial profile at the end of the treatment. That is because we utilize the growth potential in these teeth. And we're able to do a lot of arch extension. We know that with a lot of Asian malpollutions, the arch form are rather tapered, and there's a lot of crowdings, and there's not enough space for the canines to come into position. So we do a lot of arch extension in our kids and teens. And together with the decrowding or spacing, closure of spacing, teeth treatment is a combination of a lot of criteria, not only the teeth. So it's a combination of all these three stuff. And nowadays, also the muscle and the airway as well. So why Invisalign for teens? We want to utilize Invisalign for teens because Invisalign has a lot of powerful mechanics like distalization, like arch expansion, like mandibular advancement for mandibular retronacular patients. So we want to do less extraction and to make our case less simple if they go into phase 2 or if after all the teeth have been erupted. So we want less extraction with a strong appliance. And one that is facial driven, as you know, the aesthetic is very big concern nowadays in teens. And anything that's comfy and it will drive the compliance as well. And of course, all these appliances, it's gonna win the trust. If they're not painful, they're more able to accept the treatment and more able to be compliant. So what are some of the common orthodontic issues in teens? And this is everything that we're going to cover today. So this is something like a cheat sheet, okay? So we're going to talk about class 1, class 2, and class 3. And what are some of the protocols that you can utilize in these malocclusions. And I don't like anything that's complicated. For me, everything has to be simple and very effective and very precise. And by amending to all these protocols, you're going to enjoy treating your patients with different malocclusions. Not only teens, but also adults as well. And everything in pink, it means more severe malocclusions that need extractions. So you need to change your mind once you started to use aligners. It's going to be different from what you've been taught with traditional brackets. If you think like traditional, the way that you did traditional brackets, you're not going to enjoy your aligner journey. And we're going to delve into each later in our session. So first of all, let's take a look at the different treatment strategies for class 1 teens. So the most common class 1 malocclusions that we usually see in our patients are either crowdings or bimaxillary protrusion. Okay? And I assume bimaxillary protrusion is the most challenging malocclusion to treat as compared to class 2 or class 3. Because with bimaxillary protrusion, we want total distalization on the upper arch and the lower arch. So it makes it more challenging to use elastics, as we might end up with anchorage loss at the end. So let's take a look at how crowdings can be resolved in teens. So some principles for resolution of crowdings are either you look at the arch wall. The more tapered it is, the more possibility of expansion and getting space from expansion to resolve your crowdings. So always look for patients that have tapered arch wall. Those are the candidates that can do or go under non-extraction. And next, assess the tooth size discrepancy. Usually with kids, you will often see that they have peg laterals on the upper 1 tooth and 2 tooth. And if they have peg laterals, it's more evident that you have to do some IPR on the lower incisor so that we are able to finish with good and ideal overjet and overbite relationship at the end. And also assess the incisor inclination. The more upright, the more retrocline the patient is, the more room for proclination or for using proclination to create space. And also check the midline. The dental midline and the facial midline might not be coincident with each other. So the different options for resolution of crowdings are, one of it is expansion in tapered arch form. It's going to create space by performing limbally, by performing molar uprighting in limbally posteriors. It's also going to create a lot of space. Or we can do proclination in retrocline incisors, or anything with tooth discrepancy, we are able to utilize it with the IPR technique, but have to be very careful in patients with very thin biotype. And distalization are very powerful in large overjets, in a lot of crowdings in class 1s and class 2s, and even on the lower arch in class 3s. And extractions in more severe cases with AP discrepancy of more than 6 millimeter. And with those at upper and lower inclination that is more procumbent. All these methods are some of the protocols that you can utilize for patients with a lot of crowdings. So this is a small summary of some of the approaches for gaining space. And we're going to look at some of the protocols in some of the case discussion. So the first case, we're going over a class 1 crowding in which we utilize expansion to solve this problem. So this is the boy that comes in, okay? Before and after, we usually have a lot of patients in the late mixed dentition with instanding laterals and no space for canine eruption. If this is in the old days, we tend to wait. And we tend to wait until the canine start to erupt and then we put the patient at patient. However, with Invisalign nowadays, we don't have to wait. We can start the treatment early because there's the eruption compensation feature that we can utilize. So let's take a look at how I try to manage this patient. So he has problems of severe clotting, anterior crossbite over 1, 2, and narrow arches with anterior divide, and moderate occlusal plane canting. These are some of his problem list. And this is his lateral profile. He has good E-line with a very acute nasolabial angle and severe space deficiency issues. If this is the time when I use bracket, I might plan to do extractions. But now I'm doing Invisalign alignment treatment. I want to be as simple and as less complicated as possible. So I try to rethink and to jump out of the box. So I think that he has some growth potential, and there's still a long time after he finishes growth. So I think that in his 12 years of age, we can try to do knot extraction first. So he has problems of crowdings, crossbite, and occlusal plane canting. And we utilize expansion and distalization on the upper arch to create space, to resolve crowding, and for some anterior retraction to resolve his acute nasolabial angle. And we had 2 clean checks for him. On the first clean check, there are 43 aligners, and the second clean check, there are 25 aligners. So it takes up a total of 2 years and 2 months to complete his case. Let's take a look at this panoramic. Okay. When he came in, he has some baby teeth almost exfoliating. So I asked the patient to go for extraction of all these baby teeth before we do the scanning. So after we took off the baby teeth, we know that there's some space deficient over 1, 3, and 2, 3. As you can see, the space available and the space required is still a difference, and we need to expand the upper arch to create enough space for the upper canine to come into position. So what are some of the protocols for gaining space? There are a lot of protocols, including all these 10 protocols. However, we try to solve this case with arch expansion, IPR, maybe on the upper arch, especially the anterior part, to create some extra space for the instant laterals to come out and for the upper canine to distalize. And molar uprighting on the lower arch, especially in a lot of teens, we have to do a lot of molar uprighting, because if we do more molar uprighting on the lower arch, the lower 7 don't get impacted, or they don't get mesial tilted at the end of the treatment. That's what we usually get after we do bracket with patients when their 6 have erupted and 7 is partially erupted or have erupted. Usually after we finish the treatment and when the 7 comes into position, they're in crossbites. That is because the intermolar width is not wide enough to create enough space for the 7 eruption. And in some of my cases, I'll show some of the things that I'm talking about. Okay. So the treatment plan for this kid is to utilize the EC and to do arch expansion on the upper and lower arch together with distalization of the upper arch to correct the crowding and the extending lateral and the molar uprighting on the lower arch. So as you have been familiar with the eruption compensation, however, a lot of doctors does not know how to utilize it properly. So for the EC, it's actually the pocket to receive partially erupted or unerupted teeth into position. So it has a lot of advantages. It is able to serve as the space maintenance or the space maintainer after the space is wide enough for the unerupted teeth. And you are able to control the width with your ClinCheck design. And after the space is regained, you can also use it as a method of a regainer to perform anterior proclination and posterior distalization. So by controlling the width, you're able to control the adequate space for the unerupted canine or premolars, which usually they come into position later in the age. So this is one of the eruption compensation in the patient. As you can see, that the eruption compensation is not touching the tip of the canine. This is not really good because the teeth will be bulging out. So with the correct use of eruption compensation, it has to touch the tip of the canine, okay? So that it will go in. You can see that with the eruption compensation, we are able to monitor the width and monitor the path of eruption of the unerupted teeth in position. And it's a very great feature to utilize if you treat a lot of patients in the late extension. And you're able to start the treatment earlier. So this is another example here. My iPad is not working well. So as you can see, the tooth leaf is impacted. And then we utilized the EC here, as you can see. Okay? When it's erupting, we have to have it go into the pocket so that it will come into position nicely. So every time when the patient comes back, we will see if there's any interference. We just cut it short so that it touches the teeth about 1 millimeter, and that's good enough. That is enough force to push the canine into the arch gap and allow the canine to erupt into position, into the proper position. So when it's out here, okay, sometimes we are able to pull some elastics. Okay? You can hook it here and to the lingual of the alignment. The second protocol we utilize for this boy is to do expansion. And you can see how efficient the expansion is before and after treatment. As you can see, for the interpremolar width, there is a widening of about 2 to almost 4 millimeter over the first premolar and the second premolar. So arch expansion is very predictable and very evident with the aligners. And this is on the lower arch. As you can see, a lot of doctors think that arch expansion on the lower arch is very challenging with traditional method like brackets or other forms of expansion on the lower arch. However, expansion on the lower arch is regarded as very unstable. With Invisalign, we are able to do a lot of expansion on the upper arch and on the lower arch. We have about 2 to about 5 millimeter of expansion on the lower arch for this patient, as he has a very tapered arch form on the lower arch, and he has a very weak cheek button. And the third protocol we plan for him is to have a little bit of distalization on the upper arch, so that we're able to get enough space for the canine, okay, to come into position and for the laterals to go out into the arch form. So we distalize the upper molars 1.8 millimeter on the right and 3 millimeter on the left with only the plastic aligner. And we have a little bit of IPR on the anterior. However, the tip here is to initiate the IPR in teens later in the treatment, not at the beginning, when the crowding is slightly alleviated, so you have enough clearance to perform the technique. And systematic IPR protocols. So don't set up your IPR values with a lot of numbers. Set it up with 0.3 and maybe 0.5, and group it together and try to perform it in fewer appointments rather than cutting the patient's teeth, here, there, and then. And the patient will feel that you're cutting the teeth all the time. And IPR is a very good protocol for space consideration, for midline issues, and for correction of AP discrepancies. Molar uprighting is what we usually find in our teens. We have very lingually tip molars. And it's always good to upright them. And by uprighting the lower molars, you are going to create space and you are going to create a more tapered arch form. And you also create better space for the lower 7 to erupt into a good position. And so we can see that the progress of this patient, as you can see, at the end of 1 year, we're able to decrown the upper and lower arch to a great extent. However, there's still some gaps. Okay? So I asked the patient to use the class 2 elastics together with the inverted V to help settle the canine. However, if you have time and the patient is not very eager to finish the treatment, you can just wait and utilize the attachment and to allow for extrusion. However, I want the patient to finish earlier, and we also want to finish earlier. So we usually utilize the inverted V if we want to close the gap. And this is the additional aligner and the finish at the end of the treatment. So these are some of my elastic protocols when I try to use with my patient. So it's very easy and simple. It's only with class 2, class 3, up and down, and the transverse line. And these are some of the prescriptions I use. And we test the upper and the lower arch form for the patient. With the Invisalign, it's a very powerful tool for arch expansion and for arch development. And look at his smile, the before and after. And even with this severe crowding, without extraction, we didn't destroy the face. Look at his lateral profile, the nasolabial angle. Can you imagine if you try to extract the patient at the start? What will his face be at the end of the treatment? Even with a liner, we're able to maintain his profile at the end of the treatment, and we didn't flare the incisors because of the very powerful mechanics of anchorage of the aligner system. So this is deployed with a lot of crowding, with a lot of space deficiency. We do it by extraction and look at how his face has transformed into a more balanced and harmonized facial profile. That's gonna give him a very good aesthetic for the rest of his life. And it's also gonna help with his oral hygiene as well. And look at the root parallelism at the end of the treatment. It's very predictable because with a liner, it utilizes the tipping effects from leveling and alignment. And we're able to get good inclination at the end of the treatment. So this is what I was talking about. The lower 7 is a little bit nasally inclined when the A start to bud, okay? So if we are able to expand the lower 7 more locally, we are more able to bring the 7 passively into the position without further leveling and alignment after it's erupted into a wrong position. So expansion plus motor upwriting of 3-6 creates space for the 3-7 eruption. So always remember, if you're treating a lot of kids, expand the intermolar width on the upper and on the lower arch as well. This is his lateral safe. Look at his angulation of the upper and lower incisor. It's maintained. There's not a lot of ticking, which is a very good, powerful mechanics of the aligner system if you know how to control the torque with the power ridge and also with the aligner activation. So the key learning of this case is, first, utilize the eruption compensation in mixed dentition, especially in the late mixed dentition, so that you can start the treatment earlier, and then it will be less complicated for the patient, and you're going to see better results in which we utilize the growth potential. In a lot of problem cases, try expansion and distalization. If you're in the aligner world, if you're in this line, you need to learn how to do distalization. Distalization is powerful. If you're able to design a good distalization protocol, monitor the patient compliance, and keep track of what's happening with the plastic in the dentition. It's going to create a lot of space that you're not going to see with bracket system. And always utilize the growth potential in severe crowdings with acute nasolabial angle to perform less extractions. If you are in doubt and you're not sure, and the case is a borderline case, try non-extraction as the first set of aligners. And then you reevaluate. So you can see how the patient goes, with non-extraction, and see it with your eyes, how the aligner system is going to change a patient with non-extraction with the treatment. But not all patients can undergo non-extraction. With AP discrepancy of more than 6 millimeter and overjet of more than 8 millimeter, maybe extraction might be indicated for the patient. However, a lot of borderline, you can try non-extraction nowadays with the aligner system. So that is a very typical crowding cases that we are going to see in our everyday clinic, our patients a lot. The second case is also a very severe crowding case. The girl comes in and the teeth is buccally bulging, the 1, 3, and the 1, 4. This is the before and after. She is a class 1 severe crowding with complete crossbites over 1, 3, and 1, 4. With midline deviation, upper deviated to the right and lower deviated to the left. She has taper arches and even smile to start with. This is her lateral profile. As you can see, even though she has a lot of crowding, very severe, but her facial profile is rather firm, okay? As you can see here, she has a good E-line, okay? The nasolabial angle is not very acute, so, you might think again, is she a candidate for extraction? If you extract her at this age, you're going to bring her upper dentition a little bit further retracted or retrocline. So we have 2 sets of aligners for her as well. But for the first set of aligners, because she has a very severe crowded arch on the upper arch, the clean check comes up to about 77 aligners, and which I think is favorable and ideal for my time and for her time as well. So we try to do, okay, there's still a baby teeth here, the 8-5, and the 5-5. So we try to extract the okay, and then we try to distalize the 1-5 and bring in the 1-4 and the 1-3, and then kick out the 1-2 after the 1-3 and 1-4 are into position. So this is how our treatment plan is. So as you can see here, there's a lot of space deficiency over the upper right quadrant. Okay. So we try to extract the 5-5, not 8-5, the 5-5, the 5-5. We try to extract the 8-5 And then with the space, we try to distalize the upper right quadrant. And we do a lot of expansion of the upper arch as well. And together with some IPR on the upper anterior incisor to maintain the overjet and overbite at the end of the treatment. And we also do a lot of lower arch molar unwriting to create enough space to incorporate the 7. When it's erupted, it will come into a good position. So this is the clean check of the patient. As you can see on the upper arch, we utilize the segmental distalization over the upper right. And the IPR on the upper anterior. And on the lower arch, we just merely do simultaneous expansion to resolve her problems. I was trying to experiment with the aligner system and to see how strong it is with the anchorage. Because usually with the bracket system, with this kind of patient, we will try to do what? We're going to do banding or not a TPA to preserve the anchorage so that the anterior incisor and premolar are able to be retracted or to have space to come into position. So I tried on my clean check to do some special design for maximum anchorage preparation. By maximum anchorage preparation, it means the molar cannot move. We have to stabilize the molar. So I tried to lock the molar, the upper 6 and the upper 7. So you can see that there's no movement over 1/6. Okay, there's no movement here. So I did the maximum anchorage preparation for 1/5 retraction. After this is stabilized and this has been extracted, we're able to distalize this 1/5 into this area so that this space can be utilized by 1/4 and 1/3. So that is my thinking of how to do this case. So on the clean check, you can see that there's no movement here, okay, on the staging chart. And then segmental distalization of 1/5, 1/4, and 1/3. So you can see that when 1/5 moves halfway, 1/4 starts to move. And then when 1/4 moves halfway, 1/3 starts to move. So that is my thinking of how to do this case. And then I utilize IPR on the upper anterior to create space for decrowding and to finish with an ideal anterior overjet relationship. So that's how I plan for this case. So let's take a look at her progress. As you can see, by the end of 1 year, the resolution of the crowding had improved. And you can see that the molar relationship, only the palatal cusp hanging down, but there's not much anchorage loss over this area. So you can see, even though I didn't do the sapiometric tracing, but you can see the anchorage control is good on this patient with the stabilization of upper 6 and upper 7. And then we did some IPR on the anterior. So you can see that there's not much flaring at the end of 1 year. And then we continue with the treatment. And you can see that there's more open bites at the end of 1 year and 6 months. And that is very common to see if you have very severe crowdings in your patient. After resolution of the crowdings, you might see some open bite. But it's not a big issue. With teens, we are able to do some passive settling after the treatment by having the patient to wear the aligner less so that the teeth can come into occlusion. So there's no elastic for this patient and only optimized attachments. And you can see how powerful it is on the anterior incisor with the torque control. And this is what I love about the system. Why, you have all this passion for treatment. Because there's no appliance or there's no system, up till now that you're able to control the anterior incisor torque this nicely. And this is the upper arch. No extraction, no tabs, no TPAs, no bandings for this severe type of crowdings on the patient. And then we go into the second set of aligners, the additional alignment number 1. So on this set of aligners, we have 25 aligners. On the upper arch, our treatment goal is to do bisetting. And I did more IPL on the upper anterior to create more space for more anterior retraction because I don't want her upper lip to come out. I want it to stay, where she is now. So I did more IPL on the upper arch since the overjit, there's still a little bit of overjit to correct. And on the lower arch, we did the bisetting on both sides and also posterior molar uprighting on the lower 3-6, especially if you see the molars a little bit limbally inclined, always upright it. It will help with the lower facial height, the VD, and it will also help with the space. And together we also did some marginal adaptation so that there are no up and downs over the lower 6 and lower 7s. And this is the patient at the end of 2 years. Look at her interdigitation on the buccal right and the buccal left. The ideal posterior interdigitation here and here. And look how much extrusion of the 1-3 with the optimized attachment with no elastics. For this patient, because she lives a little bit far away and she is the single child, single daughter in her family, so she's a big spoiled. So the daddy doesn't want her to have anything that is really not comfy. So I just told her that, you must be compliant if you are not going to use the elastics. And to my amazement, it's very powerful. She's very compliant because she just wants her teeth to be fixed. And with the optimized attachment design, we're able to bring her canine into position. And I think the key here is she's compliant and she has growth potential. And with the growth potential of the eruptive force of the canine, it also aids with the adaptation of the upper canine with the lower dentition. And the arch form. Aligners are powerful arch development tools. They're really nice. If you look at the upper and the lower arch form, the arch expansion, the arch development is very powerful. As long as you have an ideal ClinCheck setup and as long as the patient is compliant. No matter how good your ClinCheck is, if your patient is not compliant, nothing is going to work out well. However, to my amazement, teens are more compliant than adults. They listen to us and they are more obedient. And this is her change in her smile, the change in her smile. Look at how much changes there is with no extraction, no tags, no bending, no transpalatal arches, and no elastics. So I think Invisalign is making so much possibility in our patient's treatment. And look at her facial balance at the end of the treatment. Can you see the nasolabial angle? It's even, like straightened. This is a little bit acute, right? The angle is less, and this is greater. Can you imagine that with this amount of severe crowding, we're able to maintain her upper incisor torque, and we're able to maintain her upper incisor position, and to have great control of the upper molar anchorage. And the ideal group parallelism after distalization, because with a lot of distalization or great amount of distalization, we tend to have a lot of tipping. However, with the smart force and the smart attachment nowadays, and the smart staging, we're able to decrease the incidence of molar and premolar tilting after distalization or after space closure, and to decrease the incidence of palatal cusp dumping because we have the G8 activation. And look at the roots at the end of treatment. And this is the seminometric at the end of the treatment. You can see the angulation. Okay, initially and after. Because usually with a lot of distalization, we tend to see the upper incisor and lower incisors will become more upright. at the end of the treatment. And we don't want upright incisors at the end of treatment because it will induce a lot of interferences. And the stability will not be good during the retention stage. So for the second case, the key learnings are as follows. So segmental distalization is very predictable in teens within 4 to 6 millimeter of distalization. But you have to be patient, okay? Stabilize the molars for maximum anchorage with aligner plastic and the CleanCheck design. So lock your sevens and lock your six if you want maximum anchorage and you want total anterior retraction in your patient with a lot of crowdings. And utilize the growth potential with acute nasolabial angle in teens. And give them another chance. Try nut extraction, even in teens with acute nasolabial angle with crowdings of more than 6 millimeter. Because according to IPR protocols, we're able to get 8 millimeter of space with IPR from 7 to 7. And together with distalization, we're able to get even more space. So if you are trying to extract a premolar of 7 millimeter, we have to rethink that. The philosophy and the planning will be different. So those are the two cases of crowdings that we can utilize in our teenage patient, either with expansion or distalization. Regarding, according to the patient's initial occlusion and his initial or her initial status. And the second type of crowding, the second type of class 1 malocclusion that you usually see in our patient is bimaxial protrusion. So some